When a patient presents with acute pain and has a risk factor for opiate use disorder, the goal is to avoid opiate use. Of course, if the patient fractured their hip or their femur or their shoulder, you may consider giving an opiate. There's a new drug called Journavx, which is indicated for acute pain. This may be helpful. It works on the sodium channel, and it's so far been studied for up to 14 days. So I would consider that, but being a regional anesthesiologist, I would consider doing a nerve block. That's usually my first go-to measure, and it usually works quite well. Of course, it depends on the pathology. So if the acute pain is related to a headache, I would consider occipital nerve block. If it's neck pain, I would consider trigger points or ultrasound-guided brachial plexus if there's a radicular component, or medial branch blocks. If it's related to rib fractures, I would do intercostal nerve blocks or paravertebral nerve blocks for physicians who are not so comfortable with those procedures because of the risk of pneumothorax, but they do have an ultrasound and experience with intervention, such as an emergency room physician, for example. I would consider doing erector spinous plane block. The erector spinous plane block, or the ESP block, is basically putting your needle on the transverse process, giving enough local anesthetic with or without steroid so that the medication spreads along the erector spinae plane, spilling over into the paravertebral space. The paravertebral space is a compartment. It's a wedge-shaped compartment in the thoracic spine. It's actually one compartment. So if you're aiming at T2, but the pathology is at T4, you give enough volume and maybe some gravity, you're going to get spread with just one needle stick to multiple dermatomes. Therefore, if there's multiple rib fractures, you could treat them, and you're not going as deep or as close to the pleura, and you're avoiding the risk of pneumothorax with the erector spinous plane approach as opposed to the paravertebral or intercostal approach. Now, if a patient presents with acute shoulder pain, often I will do a suprascapular nerve block, as well as consider axillary nerve block, but usually a suprascapular nerve block is enough to help with the shoulder pain. Of course, the joint sometimes needs to be aspirated or injected with cortisone. I tend not to inject the joint when I don't know what the pathology is, if I don't have imaging yet, so I like to do nerve blocks to the joint. Being a regional anesthesiologist, I have this luxury of being able to turn off a joint without actually having to put a needle in the joint. When it comes to the hip, there's the PENG block, which is a block to denervate or turn off the articular branches of the obturator and femoral nerves to the hip without going into the hip capsule. Of course, you can give a hip injection. However, if the patient is going for hip surgery, maybe needs a hip replacement, you don't want to give cortisone into that joint for 3 weeks before. So when it comes to acute pain, typically nerve blocks to the joint are very effective, and they can have various durations of action. I had a patient who needed surgery of her hip, but couldn't get it because she was too sick, and she couldn't get steroids. I actually did the lidocaine PENG block, and she got 2 months of relief from just lidocaine alone. Lidocaine in the suprascapular region can also give weeks to months of pain relief, even without steroids. When it comes to acute knee pain, one can consider doing genicular nerve blocks, which, once again, you're denervating the joint, but you're not putting a needle in the joint, so you're not giving any steroid there. As ankle pain, you could do your ankle nerve blocks, or foot pain, ankle nerve blocks. You could do sciatic nerve blocks for acute pain. Of course, you could also use non-opiate therapy for these patients because they are at risk for opiate use disorder. So your non-opiates, the acetaminophen, the NSAIDs, the muscle relaxants, the calcium channel blockers, which work on neuropathic pain, gabapentin, pregabalin, as well as any other analgesic that is non-opiate or opiate sparing, like a lidocaine patch. So there's a lot of ways to treat acute pain in patients at risk for opiate use disorder. It's definitely important to get a sense of the patient before you speak to them. Are they asking for the opiate by name and dose? Are they only interested in the opiate? If they come to your office asking for a Roxy 30 or oxycodone 30 milligrams, and they don't want to hear about any other option, well, most likely this patient has opiate use disorder, and you need to be very careful with this patient. If you have any questions, feel free to shoot me an email. I'm always happy to answer questions of colleagues, or even questions patients may have. If you want an official consultation and you want to come to New York, hit me up at aabppain.com. Or if you're abroad or looking for just an expert chart review, without the physician-patient relationship, you could just shoot me an email and I'd be more than happy to set up a consultation. And physicians interested in training on nerve blocks, they can shadow me or come to one of my courses in New York or elsewhere. Just go to nrappain.org, or you can just email me here and I'll give you all the information you need. Thank you so much.